Thank you, Dr. Arpan. This is Dr. Biswajit. Nishil, can you just upload the slides? By the time I'll just do the introduction part. So we have excellent presentation by Prashant and this group. So we have two cases lined up, and based on the theme on rare tumors, the first case will be a rare tumor and the second one will be a rare situation in a common tumor. So we have two cases. We'll see if we can fit in the time. And we have our eminent panelists, Dr. Amrita, who is the radiologist, Dr. Kazi, who is a surgical oncologist, Dr. Munita, radiation oncologist, Dr. Nidhi, Dr. Partho, Dr. Rusab, and Dr. Avinash are our medical oncologists in the group. So I would like to thank Jyoti for Dr. Jyoti for giving this opportunity and conducting an excellent tumor board session. So I'll take the case forward. Okay. Good morning. So the first case is a 30-year-old female. She had no comorbidities. She presented with abdominal pain, a significant weight gain of 5 kgs over the last 3 months. She generally complained of early morning giddiness for 3 months duration, which was relieved with food intake. She also had multiple episodes of seizures during this last 2 months period. They were generalized tonic-clonic seizures, mostly in the morning, and it was preceded with palpitations and sweating. So on examination, the vitals were stable, the blood pressure was okay, the temperature was normal, and she had a weight of 70 kgs with a BMI of 31. Per abdomen examination, there was epigastric tenderness, but there was no mass as such palpable, and other system examinations were normal. Skin also was normal. Now coming to the investigations, baseline investigations revealed that there was no anemia, the blood counts were good. There was no renal dysfunction, there was no liver dysfunction. The sodium on electrolytes were normal, the sodium values were in range, and the calcium was okay. So the patient so since this patient had giddiness, the one suspicious was the hypoglycemia. So multiple blood glucose levels were done, and the blood glucose levels ranged anywhere between 36 milligram to 46 milligram, which was in the range of a significant hypoglycemia. So we did a blood sugar monitoring chart, and we can see that the pre-prandial sugars were lower.
Respected panelists, may I do the presentation, sir?
Yeah, Nishil. I'll just complete this, then you can continue after the first question. So the pre-prandial sugars were low. The post-prandial sugars were high, as evidenced in the cuff. So these were all the pre-prandial sugars, and the post-prandial sugars were slightly higher. So further evaluation was done, and the blood glucose multiple levels were low. When we did the insulin values were 19.24, and the C-peptide levels were high. So an hyperinsulinemic hypoglycemia was thought of. So the first question to Dr. Amrita, this is the CT scan of the patient. Would you like to comment?
Dr. Biswajit. So we can see an intensely enhancing mass seen in the head of the pancreas. So you all have given me the size, which is approximately 3.3 into 2, which is actually quite large. What's important to remember in standard conventional imaging is that these tumors show extreme capillary permeability and hypervascularity, which is why arterial phase is the best phase to image these patients. I cannot see any obvious metastasis on that one section that you have provided me on the CT scan. However, going on to the DOTA-NOC and the DOTA-NOC PET CT, do you want to describe it, or shall I go ahead?
You can go ahead.
Okay. So I can see there is intense DOTA-NOC uptake in the primary, that is in the pancreatic tumor, as well as, a little decrease, but definitely significant uptake in the liver as well. There are multiple lesions in both lobes of liver, which show intense uptake, as well as one lesion in the right rib. So this is suggestive. So obviously the DOTA-NOC also picked up additional hepatic metastasis and bony metastasis, which we could not probably make out on the CT scan.
Yeah. So to summarize, I think there was a pancreatic mass, multiple liver lesions, and also there was some rib lesion in the one of the ribs had a lesion. So, madam, would you like to take this question on what would be the role of FDG PET and Dotanok in, especially in neuroendocrine tumors and insulinoma?
Yeah. So, as we all know, as opposed to CT scans or MRIs, which are purely anatomy-based imaging modalities, PET scans have the additional advantage of evaluating the functional or metabolic activity of a tumor as well. So here, fundamentally, two questions arise. Why not just use 18 FDG PET scan to evaluate NETs like we do for all other tumors? Why do we need fancy gallium-based Dotanok or Dotatok agents? The answer to that is most NETs tend to be relatively metabolically inactive, which means their activity is going to be similar to that of background tissues, hence we cannot pick them up. But this holds good only for well-differentiated NETs, because once they are higher grade or undifferentiated tumors, they display a more aggressive behavior similar to that of other undifferentiated carcinomas, and they show increased glucose turnover. And these tumors are then picked up with 18 FDG PET CT and could be negative on Dotanok PET CT. The second question that arises is, why use gallium Dotanok or Dotatok? Why use these specific agents? Now, we all know that NETs manifest with an increased expression of somatostatin receptors on the cell membrane, and seen in about 50 to 80% of pancreatic NETs. And so somatostatin analogs, which are bound to gallium, are used to diagnose and characterize NETs. The more differentiated a tumor is, the higher its SSTR expression, and hence the higher uptake on 68 gallium Dotatok scans. This also has excellent sensitivity, specificity, almost 97%. And another point to remember is that it has also shown to be of value in predicting response to therapy, the so-called theranostics, in which we now have literature showing a direct correlation between SSTR expression of a tumor, that is its uptake on the gallium scan, and its response to PPRT or a somatostatin analog therapy. Now, just to ensure that my point is put across, may I humbly ask one hypothetical question to Nishil if he's around? Is Dr. Nishil around?
Yes, ma'am, I'm here.
Yeah. So supposing this patient, you can see there is intense uptake in the pancreatic tumor on the Dotanok scan. So he obviously has a good amount of SSTR density on his tumor. So supposing we put him on somatostatin analog therapy and image him on follow-up with standard gallium Dotanok at 6 months. And that scan shows you complete metabolic response. However, his serum markers tend to be showing a rising trend and he continues to be clinically unwell. What would you do?
Ma'am, if it is resectable, the ideal option is to resect the tumor. Even after the somatostatin analogs, it might reduce the uptake in the Dotanok PET, but the patient is symptomatic. So best option is to go for the resection of the tumor if it is possible.
Right. Now, given multiple hepatic metastasis and all of that, supposing you hadn't resected the tumor in a hypothetical setting.
So I think the summary for that would be that you do an FDG PET because you could have two different kind of tumors. So you could have a poorly differentiated tumor which is actually not responding, and if the FDG PET is uptake is there, then you would consider for giving some chemotherapy.
Excellent.
Absolutely, I think that is the answer.
That is the right answer. Yeah. So it's just one of two scenarios. Yeah. Either it's true complete remission, in which case FDG PET would be negative, or if FDG PET shows uptake, it's because of tumor heterogeneity, that is tumor dedifferentiation. Thank you.
Thank you. We can go ahead, I think. Nishil, we'll continue. Yeah, Nishil, continue.
Following this, we did a USG-guided FNAC of the pancreatic lesion, which was showing a well-differentiated neuroendocrine tumor. Following which, we got the chromogranin A, which was elevated, so suggestive of again the neuroendocrine tumor. Following it.
Yeah. So, Dr. Nidhi, can you any other markers or investigations you would consider at this point of time?
So we can do other markers, but it is definitely a functional, well-differentiated neuroendocrine tumor. So it would not make much of a therapeutic difference. We can do serum gastrin, serum glucagon, VIP levels, but it is definitely a functional neuroendocrine tumor.
Okay. You can continue. Yeah.
Following which, we got the gastrin levels in the fasting. Gastrin level was within normal limits, and thyroid function tests were done in order to rule out the pituitary adenomas and all, which was within normal limits. And in order to rule out the parathyroid adenomas, IPTH was done, which was within normal limits, and even prolactin was within normal limits. So in order to rule out the MEN syndrome related insulinoma, these investigations were done. So the final diagnosis is a neuroendocrine tumor of the pancreas, well differentiated. It is an insulinoma. It is metastatic, both to hepatic and extrahepatic regions. Extrahepatic is the sixth rib, and MEN1 syndrome to be ruled out in this case because it is a malignant and it is metastatic. That is one of the queries.
So, Dr. Partho, you want to comment something on the MEN syndrome with association with neuroendocrine tumors?
Sir, these tumors are sometimes associated with MEN syndrome. Patient is reasonably young, so screening for MEN syndrome is a good idea for this patient.
Anybody else wants to comment? Okay, Nishil, you can summarize.
Yes, just some words about the MEN1 syndrome. It is the association of two or more of these adenomas. One is the pituitary adenomas or the parathyroid adenomas or the pancreatic endocrinal tumors, especially Zollinger-Ellison syndrome related things, that is a gastrinoma or insulinoma or non-secretory adenomas also. Any of the two, if it is there, then we can name it as a MEN1 tumor. And about 5% of the insulinomas overall, they are associated with the MEN1 syndrome. And usually these insulinomas which are associated with the MEN1 syndrome are usually malignant, and multiple pancreatic adenomas are seen, which are insulinomas. These are the few words about insulinomas associated with MEN syndrome.
Yeah, thank you, Nishil. So one point to note is that as the panelists had said, that less than 40 years are usually associated with MEN syndrome and more than 40 are usually sporadic. So I think we should keep in mind and we should consider doing screening for MEN syndrome.
Yes.
So the next few questions are on the management. We would like the surgical oncologist, Dr. Kazi, to take the next few questions. Whether primary tumor resection and metastectomy would you consider in this patient, though the patient has multiple liver mets but still a functional tumor, whether the debulking surgery will it really help? And if the surgery is not feasible, would you consider any other options of local therapy?
Yeah, hello, sir. Thank you for inviting me. Good morning. So, despite this being a functional, well-differentiated tumor, the patient has extensive hepatic and extrahepatic metastasis, and primary resection would really not be considered. And probably we will consider only if systemic therapy fails. Debulking surgery also, it needs to be some adequate amount of debulking. At least 70% of the tumor I should be able to remove in both the primary and the metastatic sites, which does not seem to be feasible at this point of time. So I'm not sure if that would also be helpful, and we would not be considering that at this point of time. And finally, if surgically not amenable, I don't think at this point of time, probably control the hypoglycemia medically, give systemic therapy, give somatostatin analogs, maybe PRRT, and those sites which remain, those can be considered for local therapy.
Any rule for radio embolization or
sure, yeah. But probably after systemic only. And similarly, if the local, the primary tumor appears to be resectable right now, so probably in the future also it should be resectable. For the liver, definitely either TACE-TARE or transarterial PRRT. And for the bone also, local therapy or local radiation can be considered if those are solitary sites. I've not seen the number of bone mets.
Okay. I think valid points. So I think the primary tumor at this point of time cannot be resected because the debulking surgery, unless you get 70% of the tumor out, it's no point in doing the surgery. So we have discussed about the role of PRRT and the EBRT. So the next questions are to Dr. Avinash. Any thing on symptom control medications, because we just discussed, and role of chemotherapy. Dr. Nidhi.
So for symptom control as well as for delaying the progression of the disease, somatostatin analogs including octreotide, lanreotide have been used. Is there a role of glucagon? No, because these tumors may be producing glucagon. Also, glucagon will cause hyperglycemia, which might predispose insulinoma to actually produce more insulin in response and cause more hypoglycemia. Instead, diazoxide with calcium channel blockers, phenytoin have been used. Chemotherapy option, capecitabine temozolomide combination is the one I most commonly use.
So would you also look at the grade before you decide on the tumor, decide on the chemotherapy?
Yes. So usually grade 1 and grade 2 are usually treated with somatostatin analogs or everolimus or sunitinib. If the patient stops responding to above, grade 3 tumors are the one or a high Ki67 with high Ki67 index. And in fact, as it was previously discussed, those who have a high uptake on PET scan, those are the ones in which we will be inclined to use upfront chemotherapy options.
Okay, sure. I think that's the point. So can we just to see the evidence? Actually, this is Nishil. Do you want to summarize quickly because we can go to the next case?
Yes, sir. Actually, insulinomas are very rare, and malignant insulinomas are much more rare. Only 5% of the insulinomas are malignant. And when compared to normal general population, the insulinoma patients have a same survival. There is no change in the survival. But when compared between the benign and the malignant insulinomas, malignant insulinoma patients have a poorer prognosis. That's what it has been indicated in this graph, which is published in a Mayo case series of around 250 cases.
So thank you, Nishil. So summarizing this case, I think the patient has just completed diagnostic evaluation. We are waiting for the management. So as discussed, I think we will have to see start symptomatic treatment as well as decide on some chemotherapy. So we can go to the next case. Nishil?
Yes. Here is a 48-year-old male who presented with melena and abdominal pain. And there was no history of jaundice or abdominal distension, and there was no mass per abdomen, and per rectal examination also was within normal limits. Following which, the patient underwent baseline investigations. Next slide. And the patient was having anemia, and but liver function tests were within normal limits. Upper GI endoscopy was done for the melena, and which was showing a friable lesion in the fundus of the stomach, which was bossulated. And colonoscopy was also done, which is within normal limits. And CECT abdomen was done. All these investigations were done in the outside hospital. Hence, we don't have images of the CECT abdomen. So there was a soft tissue lesion in the distal gastroesophageal junction, and which was of a size of 6 into 2.5 centimeter. And upper GI endoscopy guided biopsy was done, which was suggestive of malignant small cell tumor, according to the outside diagnostic report.
Dr. Kazi, would you like to take this question? How do you?
However, I need some more imaging or endoscopic information because the tumor is in the fundus, probably near the GE junction. Need to see what circumference of it is involved. Okay. Because with a biopsy of a small cell tumor, we probably don't want to do palliative surgery.
So what are the other differentials would you consider at this point of time?
Small cell tumor.
Yeah, so one is lymphoma is one, neuroendocrine tumor is the other, as we discussed.
Right.
And so at this point of time, definitely you are right. I would consider some more IHC markers.
Yeah, definitely.
Before we actually go in, unless the patient is hemodynamically unstable, then only you consider.
Still, because at a GE junction tumor, I don't want to do a total gastrectomy, probably hemostatic RT. But if it is a small localized or something on one wall which can come out with a wedge, then that is still acceptable.
Correct. So I think the learning point is that don't jump and do surgery immediately. If it's a malignant round cell tumor, the other differentials are there. So especially lymphomas, which could be cured by chemotherapy. So we need to wait for the IHC unless the patient is hemodynamically unstable. So Nishil, go ahead.
Yes.
Okay.
In the outside hospital itself, underwent diagnostic laparoscopy followed by a sleeve gastrectomy for the active hemorrhage he was undergoing. And the intra-op findings was suggestive of an ulcerative lesion in the posterior wall of the stomach with an active hemorrhage.
Dr. Munita, actually, she's not a radiation oncologist by mistake. So she is pathologist. So madam, can you?
Hi,
Discuss?
thank you. Good morning. So the biopsy, I don't know the biopsy which was reported, it does not include any IHC, but here I can see that this is a tumor which is not looking like a carcinoma, which are more common in this site, but in fact, like a sarcoma, the tumor cells are spindle, they are very closely packed and they show significant pleomorphism and anaplasia, which tells me that it is high grade, and mitosis are frequently seen. So at this part, with the photographs, I can see that it's a spindle to epithelioid malignant tumor, which is predominantly submucosal with areas of necrosis and marked pleomorphism. So high-grade sarcoma, and the first possibility being GIST, that needs exclusion in this setting. So a panel of IHCs would be required, and I think those were done. Yes. So this panel of IHC was mainly would be mainly looking at the different lineages, whether the tumor is GIST, for which we do CD117 or CECT and DOG1, which I can see is negative. And the other tumors are the smooth muscle tumors, leiomyosarcomas, and the neural tumors, nerve sheath tumors, melanomas, which can be spindle. So all these markers have been done, like SOX10 and HMB45 for melanoma, which is negative. Caldesmon is negative, which is a smooth muscle marker. Desmin muscle marker is negative. And lymphoma marker LCA has been done. So a large panel of markers have been done to delineate what is the lineage. And so this is essentially a sarcoma, and Vimentin, which is a mesenchymal marker, is positive. So what the only information that we can get from here is that CECT negative, so CECT and DOG1, which are markers for GIST, that is negative, and the other markers have also not delineated any specific lineage. So it's still the possibility of a CECT negative GIST remains.
Yeah. Okay. Dr. Partho, what would you do next? Is Dr. Partho available?
If not, we can move on to the next.
Dr. Nidhi?
So I think the surgery has been performed, correct?
Yeah, surgery is completed, yes.
So based on the size of the tumor and the mitotic index, we will plan adjuvant therapy. But before that, we need to do a mutation analysis of the kind of mutation, especially it being CECT negative and DOG1 negative.
So what is the molecular study you would request?
Sorry. NGS or a PCR study would be required to find out which whether it has a KIT mutation or a PDGFR.
Okay, so you would ask for a CKIT mutation initially, right?
Yes.
Okay. So the CKIT, this is the result. So CKIT exon 9 and exon 11 were negative. Would you be happy with this, or would you want something else?
So there are rare mutations like on exon 13 and 17, which could be tested, or PDGFR is one, which is seen in almost 5 to 10% cases. So that will be the one.
Okay. So how common have you seen a CKIT, the DOG1 negative GIST, and is that very common in your practice?
No, during my training at Tata Memorial, I remember 2 patients, but not in my clinical practice. I have seen both negative.
So in this situation, we did not do a 13-17. So what would be the next marker would you ask for?
PDGFR.
All right. So this is the PDGFR report. And PDGFR exon 12 was mutated, and exon 14 and 18. So I'll just summarize this because it's one of the uncommon PDGFR mutation again. Exon 18 is the most common, and you see around 5 to 7% of this GIST patients have only PDGFR mutation, and exon 18 is the most common. 12 and 14 are very, very rare. And so with this, what treatment would you want to give? Dr. Nidhi, I'm not sure if the other medical oncologists are there. Dr. Avinash is there. Dr. Rushabh?
Yes, sir.
Yeah.
I'm Dr. Rushabh here.
Yeah, Rushabh. Yeah, please.
Sir, from what I've read, except exon 18, other mutations are still imatinib sensitive. In exon 18, most common is 842B, which is resistant, and rest may be imatinib sensitive. So, if based on baseline histology, there is involved risk and adjuvant, then I will consider imatinib.
Okay. So I think the patient was started on imatinib 400 and currently on treatment. So to, I think, summarize, we are running short of time. So I think the second case was basically a case of GIST, which was commonly we have a CECT positive GIST, but this was a CECT negative, dog negative GIST. And it's important that we should not miss out doing a PDGFR, because if you have a PDGFR mutation, these patients can still respond very well to the TKIs like imatinib and nilotinib. So I think thank you. I thank the panelists for being part of this, and hand over back the session to the chairperson.